Topic is new insights into the therapeutic strategies for obesity and diabetes. I think part of it has been covered by the first session speaker, Dr. Rana Bhattacharjee, who had covered significantly about obesity management, the current management. I'll be talking mainly into a few newer insights, and they're in the preliminary stages, but just they'll help us in understanding how the obesity science is evolving and how the new targets for obesity management are there. So why we are giving so much importance for obesity these days? So because obesity is increasingly prevalent, and this is data from the left hand, the India map shows overall the obesity prevalence in many areas. The red color is more than 25% prevalence. This is as per the Asian Indian cutoff of BMI of 25 is considered as obesity and BMI of 23 is considered as overweight. So as compared to Western countries and Caucasians where they consider a BMI of more than 25 as overweight and more than 30 as obese, in the Indian scenario, we take BMI of 25 as obese and BMI of 23 as overweight. So the red color you can see on the left side, the overall India map, which is both urban and rural areas, where the BMI, we can see most of the southern regions, the BMI of more than 25 is seen more than 25% of the population. That is 1 in 4 is obese. Whereas the top graph on the right side, the red color, almost the whole of India is in red color. So urban areas, the clear prevalence of more than 25% obesity prevalence. So rural areas are also catching up slowly. The urban-rural divide in obesity is reducing. And that is why we are concerned about obesity. We know that obesity is the harbinger of diabetes and other metabolic problems. So if we cut obesity at the root stage itself, we can reduce the prevalence of diabetes, pre-diabetes, and various metabolic disorders. This is the metabolic, the ICMR INDIAB study of the prevalence cross-sectional study, which was published last year in Lancet, about the prevalence of non-communicable diseases in India. So diabetes is estimated that nearly 10 crore population has got diabetes, and nearly 236 millions, that is 23 crores, have got dysglycemia, either diabetes or pre-diabetes. It will come to around 25% prevalence. Obesity, generalized obesity, another 254 million. And abdominal obesity, 350 million. That is 25% will be obese. And if you take abdominal obesity as criteria, around 35% is obese. And that is why we need to look at how we are going to manage the obesity. The common obesity treatment as generally followed is lifestyle changes with diet and exercise, physical activity. Often we find that patient compliance to these measures is difficult, and people cannot lose more than 5% of the body weight with this. And even if they lose, we know that weight is like a yo-yo phenomenon. Whatever they lose tends to come back. So pharmacological measures for obesity, we have been using some drugs come and then they go off with due to side effects. We had fenfluramine, we had lorcaserin, we had sibutramine, we had rimonabant. So many drugs came and went off. So there was a huge vacuum in the pharmacological space. And recently, this vacuum is being fulfilled, as shown by the previous speakers. Dr. Rana Bhattacharjee had showed the GLP-1 receptor agonists are filling up this space fast. So bariatric surgery is effective, but it's invasive. So if possible, patient wants to avoid that, and there can be recurrence of obesity also after bariatric surgery. So this graph already the previous speaker, Dr. Rana Bhattacharjee, had showed the effect sizes of different current obesity therapies. So the left side one, the green color one, lifestyle intervention, diet and exercise, which is the foundation for any weight loss regimen. So can give up to 5% weight loss only. This is the graph shows the percentage weight loss. So Orlistat is the only licensed drug for obesity currently in India. And we can see that it's not very potent agent. It can give less than 5% weight loss along with diet and exercise, which translates to around 3 to 4 kilogram weight loss, which is not sufficient for most of our patients. Phentermine topiramate combination can give up to 10% weight loss, but that combination is not available in India. And bupropion, naltrexone, again, that combination is not available in India. Both are not very potent agents. So we had liraglutide, which was licensed for use in India, but it was mainly in the diabetes usage dose where we use up to from 0.6, we escalate up to 1.8 milligram. But the weight loss dose of liraglutide is actually 3 milligram, which has not been licensed in India. So now pharmacotherapy has moved on, and all of you will be aware that internationally, semaglutide and tirzepatide have revolutionized the weight management. Even semaglutide, we use a higher dose as compared to diabetes patients. That is 2.4 milligrams subcutaneous weekly once, whereas the diabetes dose is 0.5 to 1 milligram subcutaneous weekly once. In India, again, this injectable semaglutide is not available. What we have is oral semaglutide. And then tirzepatide is revolutionized the weight management, showing the maximum weight loss in the pharmacotherapy for obesity up to 20% weight loss. Dr. Rana had showed further about the triple agonists like retatrutide, which are under the trials. And we also have the melanocortin receptor agonist, that is the MC4R, mainly for monogenic obesity. After that, if you want more than 25% weight loss, we are looking at bariatric surgery like sleeve gastrectomy and gastric bypass. So the initial part, the semaglutide, tirzepatide, and the trials have already been discussed by the previous speaker. So I'm going to go directly into the newer insights which were discussed in the ADA 2024. So mainly, I'm going to discuss 3 new drugs which are under trials for obesity. So first agent which I would like to discuss, which was discussed and highlighted in the ADA 2024 are, one is the dual agonist T003. This is a novel GLP-1 FGF21 dual agonist showing a therapeutic potential for obesity, diabetes, and metabolic dysfunction, that is MASLD. So how does this combination of GLP-1 and FGF21 present a novel treatment strategy for metabolic diseases? So GLP-1 receptor agonist, as highlighted by the previous speaker, gives potential weight loss mainly due to the brain effects. So it has got appetite suppressing effect, improves the satiety. And in addition, it has got diabetes effect, improves the insulin secretion and decreases the glucagon secretion. Most of the weight loss due to GLP-1 receptor agonist is due to CNS effect of reduction of appetite and improvement of satiety. So we already have seen data, the GLP-1 receptor agonist like liraglutide, and then we also saw the semaglutide data, which gave up to 10 to 15% weight loss, and tirzepatide, which is a dual GLP-1 GIP agonist, which can give up to 20%, and the newer drugs like retatrutide, which are triple agonists, can give up to 25% weight loss also, but retatrutide is not yet licensed. So semaglutide and tirzepatide are licensed abroad, not in Indian setting. So how does addition of FGF21 analogs to GLP-1 receptor agonist, how does this help? So FGF21 analogs have been shown to increase the thermogenesis in the adipose tissue, improve the insulin sensitivity, improve the adiponectin secretion, and cause lipid. Also, in the liver, it reduces the lipid accumulation, improves the liver fat. So these are the mechanisms how FGF21 analog can be complementary to the GLP-1 analogs. So ZD003 is a novel long-acting GLP-1 FGF21 dual agonist. So it has got all the potential of a GLP-1 agonist like semaglutide, not as powerful as semaglutide, but 2/3 of the effect. And in addition, it has got FGF21 potency 4 times that of the native FGF21. The pharmacokinetics, it has got similar pharmacokinetic action, long half-life similar to that of semaglutide. Thereby, it can be used as an injectable preparation of once a week. So animal models for ZT003 efficacy studies show that in diabetic obese mice, so the use of ZT003 by causing analog actions at the GLP-1 and FGF21 receptors, it can cause body weight change, improve the glycemic control and insulin sensitivity. So in DIO hamsters, that is the diet-induced obesity, hypertriglyceridemia, it's shown to improve the plasma triglyceride level. And DIO mice, the MASH mice, it's shown to improve the cause resolution of the MASH, improvement in fibrosis, liver injury markers, and body weight change. So the numbers, these are all preliminary studies. So phase 1, phase 2 studies. So ZT003, by causing analog action at the GLP-1 and the FGF21, demonstrates dose-dependent, synergistic, potent and sustained body weight reduction, even more than tirzepatide and semaglutide, but the numbers are very small. So treatment for 4 weeks, only numbers are 6 mice which are studied. The blue color graph showing the lower part showing significant reduction, and the yellow color graph is the tirzepatide and semaglutide. So you get almost double the weight reduction in these mice with the use of ZT003 as compared to tirzepatide and semaglutide. They also showed a dose-dependent and synergistic weight reduction by increasing the dose of ZT003 and improvement in the liver parameters. That's a dose-dependent improvement in the glycemic control. The blue color graph on the left side shows the use of ZT003, which is more powerful than that of the semaglutide and the tirzepatide shown by the yellow color. So there is dose-dependent improvement in the glycemic control and enhanced insulin sensitivity in the mice models. So in summary, ZT003, which is a GLP-1, FGF21 dual agonist, it has got synergistic and complementary effects of GLP-1 and FGF21. It has shown metabolic superiority to semaglutide, tirzepatide, and Yuhan GLP-1, FGF21 metabolic disorder rodent models. Significant and better reduction on MASH resolution and fibrosis. Pharmacokinetic profile, monkey supports once weekly dosing. And manufacturing relies on the recombinant process. First in-human studies are expected next year. So it's not yet come to the stage of human studies, but animal studies show promise. So next agent, which was discussed in ADA 2024 this year, is HS235, which is a precision engineered activin and GDF ligand trap. So we know that when patients lose weight, they lose both fat mass and obese mass. So can we protect the lean mass, and can we have agents which can lean mass preserving treatment for obesity, which cause only fat mass loss? So genetic evidence links overactive activin mediated signaling with metabolic dysfunction. High activin signaling has shown to increase the adipose tissue, and it is also shown to a negative effect on the heart. HS235, which is a ligand trap for activin and GDF, that is a growth differentiation factor, has shown to improve the heart function, reduce adiposity, and improve the muscle mass. Thereby, it can preserve the muscle mass and cause only fat mass loss. In studies of mice, it's shown to decrease the fat mass by nearly 60 to 75%. And it synergizes with tirzepatide for fat-exclusive weight loss in diet-induced obesity mouse model, where the use of HS235 was much more significant when compared with tirzepatide. When combined with tirzepatide, it can give 40% more weight loss than with that of tirzepatide, which will be very phenomenal amount of fat mass loss. So HS235 is an activin and GDF ligand, which can preserve the muscle mass and lead to fat mass loss. Also, it can give protection to the heart. Finally, another agent is a combination therapy of cagrilintide, a dual amylin CGRP agonist, calcitonin receptor agonist, and tirzepatide, a dual GLP-1 GIP receptor agonist on body weight loss in obese rats. So we're combining multiple mechanisms of action, just like in diabetes, where we are not using a single drug. Similarly, here we are combining different pathways: tirzepatide, dual GLP-1 GIP receptor agonist, and cagrilintide, dual amylin CGRP agonist. So we know that amylin is a non-incretin peptide with satiating properties. Amylin is a 37 amino acid peptide produced in pancreatic beta cells. It's co-secreted with insulin. Cagrilintide is a novel, long-acting acylated amylin analog that acts as a dual agonist of amylin receptors and CGRP, that is the calcitonin G protein coupled receptor. Cagrilintide has shown to induce significant weight loss and reduces the food intake. The mechanism how amylin and cagrilintide act are mainly on the CNS. They improve the satiety, they increase the energy expenditure, they reduce the body weight. Also, they have an action on the vagal nerve and the GAT. They reduce the gastric emptying, enhance satiety. In the liver, they reduce the fat accumulation, improve the insulin sensitivity. They also have an action on the pancreas where they decrease the glucagon secretion. Combinational therapy with incretins and the dual amylin and CGRP agonist like cagrilintide can target multiple pathways regulating the energy balance, which is a promising strategy for weight loss since it allows reduction of doses of each drug where the tolerance can be an issue. So in this study, the authors evaluated the combinatorial effect of cagrilintide and tirzepatide on weight loss in obese rats. So diet-induced obesity was induced in rats for around 8 weeks and from high-fat diet. So subcutaneous daily injection for 12 days. The rats were divided into various arms, 2 doses of tirzepatide, 2 doses of cagrilintide, and a combination of cagrilintide and tirzepatide. They were sacrificed after the period of 12 days. They found that cagrilintide dose-dependently reduced the body weight, which is the higher the dose of cagrilintide, higher the weight loss. And similarly, tirzepatide also caused higher weight loss. And when you combine a submaximal dose of cagrilintide and tirzepatide, when the tolerance will be better, the combination dose shown by the yellow color graph caused the maximum weight loss of more than that of tirzepatide or cagrilintide alone, which is expected. There is dose-dependent effect of cagrilintide and tirzepatide in reducing the cumulative food intake. And there's enhanced effects of combining cagrilintide and tirzepatide in submaximal doses in reducing the food intake. Combination of cagrilintide and tirzepatide can reduce the blood glucose more than the individual component as shown in these graphs. Triglyceride reduction shown in this red color bar is much more than the green or the blue color bar. So which is the combination is more effective in reducing the triglyceride than that of the individual agent of cagrilintide or tirzepatide. So also shown to reduce the steatosis, where the combination of cagrilintide and tirzepatide shown the red color bars is more effective than tirzepatide or cagrilintide alone. So to conclude from this study in obese rats, a combination of tirzepatide and cagrilintide in submaximal doses was more effective than the use of tirzepatide or cagrilintide alone with respect to body weight change, food intake, plasma glucose reduction, and plasma triglyceride reduction, liver steatosis, and fatty liver. So combination therapy achieved greater weight loss and can be a good combination, but needs to be studied in humans. Thank you.